Okay. Questions for this for the group? Last group. President, one of the X-rays you showed a transverse fracture. I think at early 2 or 3, 4 weeks, and it had that distraction, that gap there. I've found that's the kiss of death. Thoughts?
Yeah, excellent point. So we know it's elevated BMI that we can kind of objectively measure. Is that contributing to that gap? Is it fracture resorption, or likely both? We are looking at that in our study to see if we can actually quantify that and correlate. Chances are we will be underpowered to comment on that, but perhaps that's an opportunity for a multi sort of center look at that, because I think that is a potentially separate risk factor for non-union.
So that's the academic response. The practical response is, if I see that X-ray at 2 or 4 weeks in the clinic, transverse fracture, there's a gap there now. What do you do?
So absolutely, that's getting open reduction internal fixation, because even radiographically, you can see that that is unstable.
I think I would recommend fixation at that point.
Just a small question about your study. You said previous smoker versus current smokers. Was there, because we have a lot of previous smokers and not current smokers, is there any difference there?
Yeah, excellent question. So I think, here's my academic response, sorry, but we define this very, we define this very poorly in the literature. What is a smoker? What is, even current? Is that 6 months? Is it 2 months? And so, and now we have to layer in vaping and things like that. So that's a whole other conversation. So when we pool them together, I do suspect that we'll have a significant difference. We, again, lessons learned, we didn't capture the duration of like how essentially much or a dose effect of smoking. So I think that's something going forward that studies really need to incorporate.
Right. And can you talk a little bit about compartment syndrome with transolecranon fracture dislocation?
Yeah, transolecranon and all the elbow fracture dislocations, the more comminuted fracture, the more displaced the fractures, I think there's a high risk of a compartment syndrome of the forearm. You will see some of them if you see the severe injuries. I think one thing that you wanted me to point it out. So you want to really check the neuro exam. You should not send this patient out, at least watch them. The more severe ones, again, so you got to pay attention to that.
Yeah, anecdotally, we're dealing with the missed compartment syndrome from that kind of fracture in the forearm that came to us at 6 weeks out, and at that point, really, there's nothing we could do for this patient. So it's a huge deal if you miss it, frankly, in a young, active person.
I have a question to PRISM. So again, the same study. So the nerve injury, iatrogenic nerve injury seems to be really low. I feel like we should go all to Canada if you're going to have surgery, because the coded numbers are much significantly less. My feeling is that probably the number of the distal fractures that require posterior approach is less. That's why the iatrogenic nerve injury numbers are smaller in your series. Is that correct?
Yeah, so to your point, so Lisa Canada did a non-randomized a non-randomized study, a multi-center, and quoted the 6% iatrogenic nerve injury. If I look at our fracture patterns, we don't have sort of that preferential distribution. We're about 2/3 posterior approach, 1/3 anterolateral approach, and it is truly, in this series, a 1.2% radial nerve palsy rate.
You can go to Canada and we won't bag your radial nerve. You just have to wait 2 years for your surgery. So, Ed, I've seen some of those disaster cases of the elbow come to me. You showed some real bad ones there at the end. I did a elbow fusion for a 20-year-old heavy equipment operator with a destroyed elbow and previous infection, and he was the happiest patient in my clinic after a 2-year ordeal. Thoughts on elbow fusion? Any role at all in the young post-traumatic patient?
Yeah, definitely. I have done one elbow fusion. I don't believe in them, but he did great. He was a lawyer, was burnt, pinned underneath his tractor and burnt by the headlight, therefore had a bad soft tissue injury. There was no really option for me to do an allograft, so I did the elbow fusion. I see him regularly, I think every 3 years socially, and he always shows me his lack of range of motion, goes, great work, doc. But so emphatically, I would say, yes, it does work, and for the right patient, we just don't tend to do it.
Okay, fair enough. Anthony, there's a number of papers looking at radial head replacement versus radial head fixation. I find that almost always when I try and fix radial head, it's always worse than I thought based on the plain films and the CT scan. Often there's impaction or cartilage skived off, and it's a 2 or 3 hour ordeal trying to piece it all together, whereas the radial head replacement is obviously much simpler and much more durable. Thoughts on the current status between those two options?
Yeah, it's certainly been gaining traction over time, and I think I have no problem doing that for someone who's over 60, 70 years old, right? I think I really struggle with like the 20 or 30-year-olds, right? Because these are going to last 10 years, 15 years, okay? And you know that they're going to outlive their implant. So I think you have to weigh those balances. I think that there's also a level of experience too that comes with this, knowing whether or not you have stable fixation enough to get the patient to have early range of motion, prevent these other things. I think, in the case I presented, other things to look out for, like things like impaction, things like a lot of bone loss or lack of metaphyseal support, where I'm not confident they're going to get stable fixation and they're just going to fall apart. I'm going to be in the same spot anyways.
Okay. Any other questions from the audience? And if not, in the order of interest of staying on time, we'll move on to the next session. Thank you very much, all the speakers. Great talks.